Severe acute respiratory syndrome coronavirus 2 arose around December 2019 and caused the spread of infectious COVID-19 throughout the world. The virus affects millions of lives worldwide with a total of 63,839,014 reported cases and 1,479,999 deaths. The first case occurred in Wuhan, Hubei Province, China on 29 of December 2019, in which 4 cases were diagnosed with the acute respiratory syndrome of unknown origin related to the local seafood market. Meanwhile, the outbreak itself started weeks before the Chinese Spring Festival in January 2020. During this time, many Chinese people visit their relatives' house and a lot of tourists visit China for sightseeing and to celebrate the start of the Lunar New Year. As the virus spread very fast in Wuhan and states nearby such as Beijing and Shanghai with 1,975 confirmed cases and 56 deaths on 26 of January, the World Health Organization had to declare the outbreak as a public health emergency on 30th of January. The SARS-CoV-2 is extremely infectious, transmitted worldwide only in a short of time. It can be passed directly from person to person by respiratory droplets through contact and fomites. Furthermore, COVID-19 is driven by the features of the causative pathogen, the host, and the environment. Patients with COVID-19 will experience cough, fever, fatigue, respiratory illness, and shortness of breath, which often lead to pneumonia. When the worldwide pandemic was announced by WHO on 11th of March 2020, the COVID-19 cases reached 118,000 cases across 114 countries around the world and 4,300 deaths were reported. However, after 9 months into the pandemic, the United States reported as one of the worst affected COVID-19 in the world, followed by Europe. Most of Africa and Asia are in the middle zone, where Africa reported 1,506,405 cases and Asia reported 10,830,495 cases. The reason why the most recorded cases and deaths occurred in more developed countries like Europe, Italy, and America than the least developed countries, Africa, Bangladesh, and India, for example, is because these countries lack testing capacity and they are barely managing other outbreak diseases as well. They had to impose a strict lockdown early to prevent any virus from spreading in their community. As the pandemic spreads to LDC's countries, there is worldwide concern about the risk of extreme COVID-19 mobility and transmission in populations with a high prevalence of comorbidities. Besides, the spreading of COVID-19 in the LDC's population will make the community's health worsen, as the LDCs already have a maximum capacity of existing health systems. More importantly, it is hard to predict the interaction of SARS-CoV-2 in countries where infectious diseases like malaria, cholera, chikungunya, HIV, dengue, and tuberculosis are actively spreading. Even though COVID-19 is less severe in children compared to adults, many children in LDCs experience pneumonia, which will make COVID-19 infections become more severe. It might be worse if pediatric respiratory facilities, including multiple severe comorbidities and treatment for pneumonia, are absent. Besides, there is a possibility of respiratory disease risk factors, for example, undernutrition, air pollution, being immunocompromised, and multiple co-infections are higher in LDC than in MDC. As of 28 of April 2020, the World Health Organization reported 16,469 confirmed cases of COVID-19 and 472 deaths in LDCs, affecting all but 6 LDCs. In LDCs, there are not always enough doctors to treat them. For example, a country like Zambia only has 1 doctor per 10,000 patients, and in Mali, there are only 3 ventilators per million people. There are only an average of 113 hospital beds per 100,000 inhabitants in LDCs. That's less than half the number in other developing countries. In addition, these countries cannot open a new health facility due to debt and have poor health systems. Unlike the high-income countries, they can open a new health facility at any time to keep their economy stable and live. Suppressing the spread of COVID-19 through lockdown and social distancing is more difficult to practice in LDCs. They have resorted to similar measures like other countries, such as closing schools and universities, prohibiting public gatherings, and banning international as well as domestic travel. But this restriction will force the LDC's economies to recession. LDCs cannot use testing, tracing, and isolating strategy because they not only lack the necessary testing capacities, but the technologies to effectively and efficiently trace and isolate the infected. Most LDC economies rely on external demand from developing countries. The successful integration of LDCs into the global economy brought many LDCs close to graduation from the LDC category. For example, Bangladesh, Cambodia, or Myanmar are LDCs that have garments manufacturing as their main development driver in order to free from the LDC category. These countries not only benefit from the trade preferences in most developed and major developing markets, but they also have low production costs and effective domestic policies supporting the sector. This pandemic has caused a demand shock through massive garments order cancellations from developing countries. Also, the manufacturing factories in LDCs are forced to close, causing the garment section to have no domestic supply. At the end of March 2020, a quarter of the 4 million mostly female Bangladeshi garment workers had been fired, and it continued at the first half of April 2020. Garments exports from Bangladesh declined by more than 80% on a year-to-year basis. This is causing the economy to collapse badly due to COVID-19 pandemic. Since the pandemic seems to not meet an end, scientists are pushing forward with efforts to develop vaccines to slow down COVID-19 and lessen the disease damage. Throughout 9 months of the pandemic, a total of 143 vaccine candidates were proposed in a preclinical evaluation. Among them, 46 candidates were tested in human clinical trials. One of the promising vaccines developed by Pfizer Incorporated and BioNTech SE is a mRNA-based vaccine, BNT162b2. It has been tested in phase 3 trials among 43,538 participants on 27th of July. From a total of 43,538 participants, 33,955 received a second dose of the vaccine on 8th of November 2020. The efficiency of BNT162b2 is 95% effective against COVID-19 in 28 days after the first dose. Though the efficiency was constant across gender, age, and ethnicity demographics, the clinical trials showed that the efficiency in adults over 65 years old of age was over 94%. More than 10 countries have ordered the vaccine, including the United Kingdom, United States, Japan, Mexico, and Malaysia. However, while most people are eager to have access to a COVID-19 vaccine, there are people in least developed countries who may have to wait years longer to have access to COVID-19 vaccine. The production of vaccines required in advance order from countries to secure the vaccines, which will cost $10 to $40 per dose. For example, Pfizer charged $19.50 per dose to first 100 million doses, and each person requires 2 doses, putting its cost at $39. This will put LDCs at a disadvantage because they simply cannot afford most of the new vaccines that are just being produced. In addition, LDCs also lack the facilities to transport, store, and distribute the vaccine if they were to purchase the vaccines. The transportation will be a huge challenge during this pandemic. It could take up to a few years to distribute vaccines to every country. Especially when handling a large amount of vaccines, special care is needed. Some vaccines require ultra-cold chain storage. For example, vaccines from Pfizer have to be stored and maintained at -70 degrees Celsius through a system of deep-freeze airport warehouses. Even if less developed countries are able to buy the vaccines, they may lack the transportation facilities and road networks to deliver the vaccine to their people, thus decreasing the efficiency of the vaccine. The coronavirus crisis is a deep and sudden shock. During this pandemic, the LDCs are the most affected in terms of economy, health, and technology. As COVID-19 threatens less developed countries, collective intelligence and technology can help by providing insight into the pandemic and how to respond. For example, LDCs can use demand mapping methods for medical supplies in which frontline workers and emergency responders could use existing technology like frontline SMS to report on missing or low supplies of key equipment to a common website. Next, using smarter search response by modifying symptom reporting tools for community health workers would allow governments and humanitarian agencies to identify potential virus hotspots and control the search capacity. With these approaches, the LDCs can reduce the possible risk of high COVID-19 cases and be more prepared to fight the pandemic.